Oh, connected. Yeah, just now.
Not because I suffer fast, not because I pray and fast. No be your show, no be that. I'm watching. Daily, Osinachi. I'm no qua, Osinachi. One man, Osinachi. I'm watching. Daily, Osinachi. Mama, Osinachi. Not because I suffer fast, not because I pray and fast. No be your show, no be that. I'm watching. Daily, Osinachi. I'm no qua, Osinachi. One man, Osinachi. I'm watching. Daily, Osinachi. Mama, Osinachi. kéré sí nọ́mbà wa, àwọn ọmọdé wọ̀nyí kéré sí nọ́mbà wa.
Wọ́n kéré sí nọ́mbà wa. Wọ́n kéré sí nọ́mbà wa.
Not because I suffer fast, not because I pray and fast. No be your show, no be that. I'm watching. Daily, Osinachi. I'm no qua, Osinachi. Man, Osinachi. I'm watching. Daily, Osinachi. Mama, Osinachi. Not because I suffer fast, not because I pray and fast. No be your show, no be that. I'm watching. Daily, Osinachi. I'm no qua, Osinachi. Man, Osinachi. I'm watching. Daily, Osinachi. Mama, Osinachi.
Who sent this to me?
Good afternoon, everyone. I think we are still going to wait for the panelists for this panel on the politics of motherhood, midwifery, and child health care. Probably they are having some technological issues, so we have to wait for a while for them to get connected to us, say 5 minutes. Hello, everyone. I just got updates from my co-chair. She's having a little bit of difficulty connecting to her system presently. So I think one of the presenters is already online. Probably would stick, wait 5 minutes before getting started with today's session. Please kindly be with us for 2 minutes more. Very good.
I think one of them is China versus presenting.
what wasting for that, I think we are in students. I'll start using
Hello, everyone. I welcome you all to this panel. Okay, I was about to talk about the chair who I think is having connection issues. Yeah, she's back now, and I think we can start the panel now. Thank you.
Sorry, I had a little bit of a network issue. Can you guys hear me?
Yes, we can hear you.
Oh, okay. Like I was saying earlier, each presenter is going to present their papers for 20 minutes. After the presentation, we'll go straight to the question and answer session. We want to start with Matthew Oluwaseun Ayodele. He is a bachelor and master's degrees. He has a bachelor's and master's degree in history from the University of Ibadan. As a historian and body scholar, his scholarship sits at the intersection of earth history, religion history, women's studies, and gender history, and sports history. His MA dissertation critically examined reproductive health promotions and advocacy by state and non-state actors in colonial and post-colonial Ibadan, southwestern Nigeria. His research has received support from local and international bodies. He was a recipient of an Erasmus Plus grant from the Department of History, University of Ibadan, and recently completed his exchange program at the Institute of African Studies, University of Leipzig. He is going to be presenting a paper on traditional healthcare practice in Nigeria, maternal and child health promotion in colonial Ibadan, 1921 to 1950. So over to you, Matthew.
All right, thank you very much for the introduction. So as rightly mentioned, I'll be presenting a paper on maternal and child health promotion by traditional specialists in colonial Ibadan. This is a chapter in my master's thesis, and I'll be happy to receive significant feedback. So I don't know, can I share my screen or?
I'm sorry, before you do that, I would like to crave your indulgence, everyone, to put on your video so that we can take a promotional photo of this panel. Thank you. And we're waiting for Dr. Faye Shara.
Wait. Can you probably wait for some minutes because we're having.
Okay, fine. Okay.
Just give us. Matthew, you can go ahead and present your paper.
Okay, can you see my screen? Sorry, please, can you, I'm sharing my screen now. Can you see that?
No, not yet.
Yes, we can see your screen.
Okay.
Oh, okay, it's come up now.
We can see your screen now.
All right, thank you. So once again, I'll be presenting on traditional healthcare practice in Nigeria, maternal and child health promotion in colonial Ibadan, 1921 to 1950. And this research paper actually emanated from the from existing scholarship about about health development in Africa, which some scholars actually claim that it's dependent on a foreign intervention, and also the fact that the argument about malaria eradication in colonial Nigeria, maternal mortality, increase in reproductive rate in colonial Nigeria, all these things like in the colonies have actually been attributed to Western medicine. And now it's just a way to rethink all these things and then to decolonize our history as well. And to some extent, we've seen that like existing scholars such as Rodney have actually like engaged issues like this about talking about the incursion of talking about Western incursion into Africa as rather a setback to pre-existing progressive development in Africa. And then other scholars such as Taiwo, Ofiong, Mapara also commented about this transatlantic slave period, capitalism, colonialism, imperialism, as the basis of Western relations with Africa. And much importantly is the argument about Western medicine, which the likes of Konadu, Miller, Paul actually commented that it's led to a divide in health accessibility and it's undermined and stigmatized traditional healthcare in Africa. And Abdullahi further commented that indigenous knowledge systems were not given opportunities to systematize and develop in Africa. Now, the major concern right here is actually to look at how colonialism itself actually downplayed or relegated traditional healthcare in Nigeria, but specifically in colonial Ibadan. And this paper interrogates traditional medical practitioners' use of advocacy through newspaper representation and associations as tool for contesting the pluralism in the medical marketplace in colonial Ibadan. It's further explored the traditional healthcare practitioners' responses to reproductive health needs and analyze the traditional practices in colonial Ibadan. Then I have a subheading named Newspapers and Associations as Advocacy Tools, right? So the practice of medicine was indigenous to the people of Nigeria, contrary to the erroneous belief that the healthcare system was a colonial invention. We have a lot of Eurocentric scholars that have actually made that argument that yes, not until we had missionaries that actually brought some sort of Western medicine and the colonial government legitimizing this Western medicine, that the medical system in Africa or in Nigeria generally, in Nigeria or in Africa generally is quite crude. Like it's all about dark magic, it's all about juju, it's all about this. And the works of A.G. Simpson, right, and other Adio Elambo and other prominent scholars have actually explored the existence of even not just a structured medical system in Nigeria, but also a sophisticated medical system in southwestern Nigeria, even as far back as the pre-colonial period, right? Then we talk about the traditional medical practitioners that they had variant names and belonged to different groups in Yoruba land. And some are like Babalawo, diviners, Adaunshio, Onishegun, and most particularly Yard Baby midwives. Now, Babalawo consults his oracle and describes and prescribes the appropriate rituals and sacrifices to reveal the cause and cure of indicated ailments, while the responsibility of the Yard Babies is majorly, Yard Babies also known as traditional midwives, majorly to like take care of pregnant women, assist during labor and childbirth. And these traditional medical practitioners are specialists will be referred and were actually referred to as traditional healers in colonial Nigeria, in colonial Ibadan. Then the population of these traditional healers and apprentices increased in the colonial period due to the Native Herbalist Guild of Nigeria of 1885, according to the archival record. Because while researching into this, I consulted material. I sought materials at the National Archives of Ibadan, at the National Archives of Nigeria in Ibadan. So precisely, this Native Herbalist Guild of Nigeria was formed in order to preserve this traditional healthcare system in Nigeria during the colonial period. Yeah, and back to this slide is the fact that in effort to sideline the traditional practitioners, okay, the colonial government requested the formal registration of all native herbalists. There were different categories of traditional healers in Ibadan, and most of these, traditional healers started forming organizations, associations, for proper and formal identification by indigenous people and the colonial administrative system. So what is important at this phase is the fact that, the colonial government introduced all these policies to say, oh yes, traditional healers must form organizations, they must be formally recognized by the government, they must go through a formal process before they can be allowed to practice their care system in Nigeria generally during the colonial period. And basically, the next slide will then show us like how the traditional health practitioners also responded to these stifling, restrictive policies, brought about by the colonial government. And the 1920s marked the establishment of the Ibadan Native Herbalist Cooperative Society, right, formed by 4 United Herbalist nations in Ibadan, the Tunluche Native Herbalist Society, the Edas in Ibadan Native Herbalist Society, the Jebus Ibadan Native Herbalist Society, and the Kukuruku in Ibadan Native Herbalist Society, with Mr. Leasu Damolade as the president of the association, and Dr. Adbaje became the patron. The essence of this is just to like still foster this traditional healthcare system, even with all these restrictive measures introduced by the colonial government. And to add to this, was in 1921, Mr. John Ojo founded the first traditional, traditional healthcare-based newspaper named the Nigerian Herbal Messenger and Health Review for traditional medical practitioners to project their practices through the media. And what is important in this whole situation is the fact that although the colonial government was trying to, introduce this restrictive system for traditional health practitioners or traditional healthcare, all right, the healthcare system or the colonial healthcare system as at this period of 1910s, 20s, and 30s, 40s, actually sidelined the rural population too. Because when we look at the works, the research, Dr. Adeoye Lambo actually conducted about neurosis, about how, people with neurosis, how when they consult, traditional practitioners, and when they consult Western based medical practitioners, doctors, and all these things, it actually shows that, traditional practitioners actually have 60% success rates than the, the Western medical practitioners. And also in a record, one of the sources actually came about at the archive also as at the 1920s, it was stated by the colonial government that 80% of the people in the rural area don't actually have access to, to Western medical system. And the implication of this is that this rural population then primarily depended on, the traditional health, practitioners. And so while the colonial government was trying to like downplay these traditional health practitioners, okay, they were like, these traditional health practitioners adopted these measures just to, preserve their practices. Because definitely, if they are actually given to all this pressure, then the people, the rural people, the rural populated area, the people that, people from the rural area definitely wouldn't then have access to medical, Western medical care, and they will still not have access to traditional medical care as well. Then, what's another advocacy tool used by the traditional healthcare practitioners is that they increase their practice of performing traditional rituals at initiation ceremonies. They organize sex education, increase the number of young healers, and in 1926, under the Section 5 Business Ordinance, the Native Herbalist Cooperative Society of Nigeria was formed. The colonial government's introduction of formal registration of native herbalists and the required payment of €50 for herbalist newspaper registration was actually, requested. And definitely, it then took, the initiative of all these different native herbalist associations to come together and contribute for this herbalist review newspaper. Furthermore, there was also this certificate issuance system introduced by the colonial government. And this certificate system is more or less saying any traditional healthcare practitioners willing to practice must actually acquire a certificate. And let's see how this really played out, because it's constrained and intimidated most traditional healers from practicing their medicine during this period. Before acquiring the certificate, the applicants were questioned on the length of time they have been practicing, the kind of medicine they use, and the type of plants, which, if eaten, may cause death. This examination was to determine and ensure the quality and motive of such traditional healer. For instance, on March 27, 1931, a district officer in Ife reported that 6 EU native doctors returned from Lagos, where they had taken and passed a certification test. The test was noted to position them and their services to be legally recognized by the native court. As a quotation, a direct quote from the archival material, they went to Lagos and collectively paid €2, 10 euro for passing tests in which they provided their own medicine. After 15 days of test, a further sum of €1, was paid as they were given a combined fellowship and list of rules. The colonial government was, these has also done some kind of exploitative measure of also discouraging, traditional medical practitioners to practice. Colonial government was concerned with controlling the traditional healers. This made herbalists interested in practicing publicly, restricted to joining one of the Nigeria Universal and Beneficial Cure Society and obtain a certificate of membership and official recognition. Now, the implication of all this on reproductive health is the fact that, while the colonial government pushed forward initiatives such as, specifically for maternal and child health care in colonial Ibadan, while they pushed forward initiatives such as Baby Health Week in Lagos, which was, extended to Ibadan, in Lagos, then there was also this rural health unit also pushed forward to encourage, mothers to bring their, infants to maternity centers, right? However, 60% of these mothers in colonial Ibadan still did not have access to this care, to this Western, medical care system, right? And most of them still went back, and then they still consulted these traditional midwives, the Adebis, in colonial Ibadan. So it was more or less like a contestation between, retaining certain health healthcare system, and a foreign healthcare system then contesting a pre-existing healthcare system. But in conclusion, the major reason for this discourse is that according to Frantz Fanon, the Algerians avoided Western medicine as a gesture of defiance against the colonial regime. And when we also look at it in colonial Ibadan or in colonial Nigeria generally, we see that even people rather patronize the traditional health practitioners. And this conclusion was based on the following fact, because the traditional health care system was available and cheaper to access, with no official process involved, particularly in the case of maternal and child health, fueled by indigenous populace, patronage of traditional medical practitioners. Also, the fear of cesarean operation conducted by Western medical practitioners discouraged women towards government hospitals and reinforced their patronage of traditional midwives. Thus, there is a variety of deliberate and non-deliberate reasons why the indigenous populace would decline to adopt biomedicine. The active resistance of local actors to Western medicine showed how indigenous people's skepticism was based on rational consideration. This study contested Toshen's submission that colonialism eradicated African traditional medicine and that traditional healers disappeared during the colonial era. Hence, the study explored the resistance formed by traditional healers against Western, against the colonial government, forceful, imposition of Western medicine, and it identified local actors and pioneered this resistance. It is pertinent to note that traditional medicine and reproductive health advocacy in Ibadan between 1900 and 1940s was strengthened by the low cost and affordability of herbal products compared to Western products. According to the Medical Development Plan in Nigeria, prepared by G.B. Walker, the then acting General Director of Medical Services, on the 12th September 1944, he noted that the medical plan emerged as a response to the reluctance of the indigenous population in adopting Western medicine. Thank you very much for listening to my presentation. Thank you.
Yeah, Matthew, I was about cutting you short, but thank you for keeping to the time.
Yeah.
But before we move to the next presenter, I want to quickly note this question, because I understand that I want to say your presentation is more of a continuation of what was discussed yesterday in the first session. And it's interesting to see this linkages between this presentation. But I would want you to quickly note this question. What I understand that during this period we are discussing about, there were policies restricting the traditional guide, like you mentioned, from practicing medicine. And I would want you to tell us how they were able to maneuver this policy to their own benefit. Just have this at the back of your mind, and we'll quickly go to the next speaker. Okay, the next speaker that we're presenting is she obtained a PhD in cultural medical anthropology from the University of Ibadan, Nigeria. She is a research fellow at the Social and Behavioral Health Unit of Institute of Child Health, College of Medicine, University of Ibadan. Dr. Omoboale blends anthropological knowledge, theories, and methods in teaching and researching public health issues to impact society's well-being positively. She uses anthropological prism to research child and adolescent health culture. Today she'll be presenting a paper on sorry, I really don't know how to pronounce this. Discussions on childhood immunization uptake and completion among mothers in urban markets of Ibadan. Okay, I believe you make us understand that pronunciation better. So over to you.
Okay, I don't know if we can share my screen. Okay, just a minute.
Yes, you can. You can go ahead and share.
Okay, I'm trying to do that now. Okay. Okay. I don't know if you can see my screen.
Yes, we can.
Yes. Yes.
Okay, fine.
We can see your
Okay.
screen now.
Good afternoon, everyone. Okay, so the title of the presentation it's actually an extract from a larger study on childhood immunization. The title is Ọlọ́run ní wo mọ wèrè, dismissive construction on childhood immunization uptake and completion among mothers in Ibadan urban market. Ibadan urban market. So I'm going to give background. Hello, can you hear me?
Hear you. Yes, we can hear you.
Okay, thank you. So one of the issues here is that, okay, I'm going to give background to this. Among the Yoruba of Southwestern Nigeria, the market space is very important, not only to the economic development, but also to other issues, whether social, health, and what have you. And one of the things that goes on in the market is that makes the market space unique is the socialization and association that goes on in the market space, especially among different groups of people. And over the years, it has been discovered or established that there is a relationship between the public health and the market space, especially in Africa. So one of the issues that has also been established, the market space is a reservoir or housing many mothers of young children that are under 5 years of health campaigns on many communities, because people that get different world view, and then they're able to take back the message to wherever they come from. And that is one. And one of the health messages that has been taken to the market over the years is the issue of childhood immunization. But this study looked at the issue of incomplete childhood immunization, especially among mothers of under 5 children in the market, those who have come to the market space to find livelihood. And then if you look at it, in Nigeria, the routine immunization schedule spells it out that a child will have a complete vaccination or appropriate vaccination when the child has taken 1 dose of BCG, 1 dose of BCG, taking 3 doses of DPT, and another dose of polio vaccine and 1 dose of measles vaccine. But it has been found out that in Nigeria, only 31% of under 5 children have completed age-appropriate vaccine. These vaccines have spelled out here. And this is indeed worrisome. And then this study have actually also gone to the markets in Ibadan. we studied 3 markets: Oche Market, one of the traditional oldest markets in Ibadan, Nigeria; Bodija Market, the largest foodstuff market in West Africa; and Agbeni Market, which is also the largest provision groceries market in Ibadan. And we find out that in Ibadan, among these women, only 17.5% of those children have actually taken age-appropriate vaccine. And why is it important to encourage mothers to vaccinate their children? This is because to prevent vaccine-preventable diseases that could make those children disabled at early stage, or that could even increase the child mortality rate in Nigeria. So, but in our study, as we embarked on the study, we kept hearing a particular phrase from mothers and asking them, why haven't you completed your child vaccination? Even the child is 3 years, also have completed those vaccines. And they kept saying, meaning it is God that nurtures lunatic mother's child. Then we decided to probe further into this. And the study employed is an action intervention study, and we employed ethnographic methods of observation, in-depth interview, and key informant interviews. And then models of under 5 in Ibadan metropolis were used. And when we look at factors associated with incomplete vaccination among these mothers, we found out that one of the issues is the time and survival. What do I mean by this? We realized that many of these mothers, they find it difficult to go for their children's vaccination because they have to be at the clinic, sit there for 1, 2, 3, 4, 5 hours, and leaving their wares in the market without selling or even without making profits for the day. And this, for them, is not something they really want to continue. And like one of the mothers said to us in one of the in-depth services, she said, these people waste my time when I go there. And this child is not sick, and I will pray my child will not be sick. After all, alone long go more weary. So another factor we have discovered is the economic hardship. Many of the mothers also indicated or revealed that from their interview, it revealed that they find it difficult even to make ends meet that they could actually use, make their profit. They are unable to share their profit between making ends meet, providing for the home, and using part of the money to go to the clinic and obtain the vaccine. The vaccine is free, but for them, transportation, and then for them, some of the little expenses they may have to do when they get to the clinic is not convenient for them. And so for them, because the economic is hard and they are not able to do that, and many of them will just conclude by saying, well, even though they have failed in doing this, they believe along long more weary. Then another factor we have identified is problematic spousal family relationship. And many of these mothers, in the course of interview them, made us to realize that they don't have husband, but they have father of a child that loco chuboni babomo. And because they don't have their spousal support, and in terms of finances and some other form of support, social support, they are unable to completely vaccinate their child. And the conclusion will be, after all, a long more way. Then we also realized that ignorance and mis-socialization was also one of the reasons why many mothers dismiss completion of their childhood immunization of their children. And like they don't understand the reason why the child has to complete the vaccine and why incomplete vaccination is not good. And then some of them, like one of the respondents told us that, oh, my mother-in-law said I should not vaccinate my child again. that if I do, the child will not be able to walk on time and may eventually become handicapped. And this, are part of missocialization and misinformation that, as we discovered. And then we have cultural value that's of fatalism, when we believe that destiny cannot be changed and God has decided what a child will be, vaccination or not. After all, along will way. So what we have discovered, and what I'm saying is that dismissive construction on childhood immunization uptake and completion among mothers in urban markets of Ibadan, in the phrase of Oloruni Womonwere, expresses shared mistrust among mothers in urban markets, especially concerning vaccination, that has been ignited by socioeconomic inequality, ignorance and missocialization, long waiting hours, which is systemic issues, and the frustrations they have, experienced, especially in spousal familiar relationship. And the implication for farfetch, the dropouts morbidity and mobility among children of under 5 age. And it is also important that mothers in operating on urban market space should be, socialized completion of childhood immunization. The issue is not about starting the immunization. They start, but completion is the issue. And the completion, when they have failed, is when this dismissive construction comes up, expressing their shared mistrust, frustrations, ignorance, inequality, and missocialization they have experienced over time. And I want to say a very big thank you for everyone. I want to say thank you to Shivax, Institute of Child Health, University of Ibadan, and College of Medicine. Thank you.
Thank you, Dr. Omobawale, for this wonderful presentation. We'll quickly move to the third presenter because we are far behind time. The third presenter is the co-chair of this panel, Dr. Ogeshi Williams, and she'll be presenting a paper on the international origins of the birth control movement in Nigeria. Dr. Oge, can you hear me?
Yes.
Okay, over to you.
All right, I'm going to share my screen. All right, so first of all, I want to apologize for joining the session late. Everything went wrong from my end at the same time, like every single thing, from the laptop to the connection to electricity. So I apologize about that. So today I'm going to discuss the politics of birth control in Nigeria from the 1950s through the 1970s, and how Western ideas about regulating fertility and controlling world population was adapted for a Nigerian audience. And I'm going to talk briefly, very briefly for the sake of time, about my methods, and then I'll discuss British colonial approach to birth control and other population issues in Nigeria. And after that, I will discuss how the global population control movement gained a foothold in Nigeria at independence, and how their efforts were adapted for the Nigerian audience. Now, I can talk more about the methods and sources during the Q&A, but I just want to say that this paper is based mostly on archival research, and these are on the screen, some of the archives and some of the the resources that were most useful. Again, I can discuss these in the Q&A. So when it comes to British attitude to birth control in Nigeria, it was really a non-issue. Birth control was really a non-issue for the colonial government in Nigeria, and a subject that they did not engage up to the 1940s, partly because they did not have a reliable demographics data for the entire colony of Nigeria to make decisions on population control. Now, a lot of the data that they had were flawed, and it was based on estimates and projections from previous years. And the government was also beginning in the 1930s to confront maternal and infant deaths in Nigeria and the fact that many children did not survive childhood. Now, the one part of Nigeria where reliable demographics information and mortality or morbidity data existed was Lagos, because it had been the seat of the colonial government for a while. And there were laws since the early 20th century that required registration of birth and death. Now, in 1943, all of this changed. Population control became a subject of much discussion in the colonial office, not just in Nigeria, but other parts of West Africa. And this dialogue was mostly a result of letters that the man on the screen, Julian Huxley, wrote to the British Colonial Secretary of State, asking for preemptive birth control policies to be enforced in West Africa. In response to this letter that he wrote, and I have the excerpt on the screen, where he states that, you know, death rates are reducing, healthcare is improving, so why don't we just introduce preemptive population control measures? So in response to this letter, the Colonial Office stated that there was room for population growth in Africa, but they were also very conscious and wary of how any population control policies through contraceptives would be seen by Africans as a trick to destroy Black people. And this was largely because of their experiences elsewhere. Now, in this file that I have on the screen, Birth Control West Africa, there were multiple references to the West Indies and how Black people in the Caribbean reacted against birth control campaigns. You know, it was tied to the eugenics movement, and it was confronting this view that Black reproduction was flawed, that something was wrong with Black females and Black reproduction, and you know that the eugenics argument that the white by Blacks. So there was a big backlash against any efforts, any birth control campaigns in the West Indies. And so in this document, you see a lot of that sentiment flowing into that, where the Colonial Office was arguing that, well, if we did something, it might be interpreted this way, and then we might get ourselves in a mess, just like we are in the West Indies. So that was the initial reaction. So the Colonial Office decided to wait for the final product of a survey that was already underway before it took any actions on population. And this is a survey that I have on the screen, a demographic survey of the British Colonial Empire, Volume 1 on West Africa. Now, when this survey came out, the government maintained the status quo and did not adopt any birth control policies. Now, in fact, what the government did was to relocate population from areas in the southeast that were densely populated per square kilometers and therefore led to overused, unproductive lands to other parts of the southern provinces that were considered very fertile but sparsely populated. Now, these resettlements would then become centers for cultivated palm oil plantations, if you will, which was an important cash crop at the time. Population for Britain was a human resource that was very crucial for colonial extraction. So every interpretation of population problems were seen under the parameters of economy and labor supply for Britain at the time. Now, for the rest of Nigeria's colonial history, the British administration did not push birth control. Now, beginning in the 1950s, however, US influence began to increase in British colonies and elsewhere, and the population control rhetoric that had become firmly established made its way to Nigeria, largely through some of the foundations that I have on the screen, the Population Council, the Ford Foundation, these are both US entities, the International Planned Parenthood Federation, the US Agency for International Development, USAID, also played a direct and indirect role in what had at that time increasingly shifted from eugenics rhetoric to largely a birth control rhetoric for the purposes of managing world resources. Now, the Population Council itself became instrumental in the implementation of birth control interventions in Nigeria, and they would go ahead and fund several family planning clinics around the country. They also concentrated family planning clinics in the West, in Western Nigeria, because of the higher concentration of hospitals and health workers in parts of Western Nigeria, notably the Lagos-Ibadan axis, which were the center of colonial and post-colonial administration in Nigeria. Now, when they introduced these measures, they were met with passive resistance to their birth itself in the 1960s, distanced itself from population control rhetoric and would not create a formal birth control policy. Now, when it finally did create one, the National Population Council, this council merely just served as a clearinghouse for the various local and international countries still would not take a stand. Now, I want to talk about some of the oppositions that they actually met and how they reacted to these. The Population Council and Ford, along with their foremost local partner in Nigeria, the Family Planning Council of Nigeria, met with resistance on multiple fronts. And there was a religious argument. On the religious and moral grounds, many Nigerians believed that birth control was a license to promiscuity and the promotion of immorality, especially among women who could now hide their deeds of immorality by escaping pregnancy. That was one of the major arguments and backlash. And then on health grounds, people simply believed that it was a Western ideology that went against the local tradition. If you remember the two newspapers that I had up in pages that were dedicated to these debates over birth control and eventually over family planning. Now, on the one hand, nationalists also believed that this was a ploy by the West to reduce African population, but also to sabotage its military ability to challenge Portuguese colonialists and the apartheid government's influence in Southern Africa. Because at the time, these were some of the leftover colonial strongholds on the African continent. And these arguments were made by and pushed by people like Ken Saro-Wiwa. Now, in response to these oppositions, to make inroads in these communities, the Population Council, Ford, and the Family Planning Council of Nigeria rearticulated their argument in favor of birth control to suit local circumstances. So they shifted away from that rhetoric that, there's going to be amalgam if we don't do something about the world population. They realized, well, the locals do not care about amalgam, or that the world will collapse all of a sudden if nothing is done about population growth. Now, the argument became that modern contraceptives was in line with tradition in Nigeria, in which women breastfed and abstained for about 3 years as a method of birth spacing. So this became some of the arguments that they started going into the communities with. They moved away again, like I said, from that global population control rhetoric and focused instead on the strain that too many children caused on the family, as well as the economic and health benefits of regulated family sizes. You can see some of the campaign posters that I have on the screen. These kind of became the focus as opposed to this global, let's control the global population rhetoric. Now, one of the tactics too was to target medical personnel for support on contraceptives use. And the logic was that medical personnel were likely to come in contact, could in turn sway women's opinions doctors against the use of various forms of contraceptives devices from the West. Now, one of the moves that was made in connection with medical personnel was to create a postpartum program and make family planning and birth control a core part of this postpartum care. And so in 1969, Ford and Population Council would identify the Lagos Island Maternity Hospital as the prime location for a postpartum program because they believed the hospital was the largest maternity hospital in Africa. And so it was the perfect spot to start this postpartum program. In this program, they ensured, and I can talk some more about this program too later on, but in this program, they ensured that normal and complicated delivery patients returned to the hospital for postpartum care. Now, before then, before 1969, only women who had complicated deliveries, cesarean sections, returned for postpartum care. Women with normal delivery just went on their way after they had their babies. So now they pushed for women with normal delivery and complicated delivery to come back for postpartum care. And they made nurses and midwives trained in birth control methods in charge of postpartum care, so that birth control now became the heart of this postpartum program. Now, besides doctors, university professors were also targeted for disseminating birth control information because of the belief that they routinely came in contact with younger members of the society and so could carry the message of birth control to the group if they themselves are convinced about the importance of birth control. And so funding would increase for this group to sponsor projects, any projects remotely connected to birth control. And interestingly, the American Home Economics Association in particular focused on home economics associations in Nigeria to bring them on board and spread family planning information through them due to the understanding that they worked closely with families, particularly women and girls, and would be able to get them on board birth control. Now, one of the obstacles that the birth control movement faced in Nigeria, was the requirement that women needed signed consent from their partners and spouses to get birth control pills or devices. Now, a significant number of men at this time were opposed to birth control in the first place, and so they would refuse to give these consents and threatened police action against the hospital, but also against their wives if they went ahead and got contraceptives. Now, what many women did was to pay forgers. This became the subject of conversations in the Daily Times and the Observer, that women were paying forgers to forge their husband's signature or forge the signature themselves. And others simply went to chemist shops and bought the pills. In these chemist shops, the written consent rule was generally not followed. And so part of the goal for Ford and the Population Council and others became to reach out to men and get men on board with birth control. Globally, the birth control movement, family planning, had always focused on women, while ignoring the fact that although women sought for ways to control their reproduction, men often had quite a bit of say over the decision to take the pills. Throughout the 1970s, campaigns were therefore targeted at men's education regarding birth control. By the 1980s, the global population control movement had come under attack at in various parts of the world, including in major global organizations. Funding began to decrease, and the sway that they once held began to decline. In many of these locations, fertility and population growth, places across the world, fertility and population growth rates were already on the decline, independent of any population control interventions. And the world crisis that was predicted back in the late 40s and 50s had not materialized. So those who were truly interested in women's reproductive rights wanted a more direct focus on issues that concerned maternity. And with the benefit of the demographics data that was generated by family planning organizations and the Population Council, world attention shifted at this time to maternal deaths. and the safe motherhood era. And within Nigeria itself, this global shift towards safe motherhood also shifted international attention and funding priorities from family planning to maternal deaths and safe motherhood. And I'll conclude quickly by just stating that, as I work on this, this is a work in progress. It's going to probably end up as an article, but also as part of a book chapter. And one of the issues that this topic raises for me, and I hope for us maybe, is the dependency of the maternal health sector in Nigeria on foreign aid. I talked about how the birth control movement was kind of dependent on foreign intervention, family planning as well. Now it raises a bigger issue for me and perhaps a broader reflection on aid and when it becomes hurtful. The health sector in Nigeria is already underfunded, only 4% of the budget, last I checked. And investment by Nigeria in the maternal health sector is even more sparse. So while international aid is important, I keep wondering how this setup can be established in such a way that there's a buy-in, a significant level of commitment from the federal and local governments. And on that note, I'll just end. I have some other stuff that I wanted to conclude with, but I know we're out of time, so thank you.
Dr. Williams, thank you for your presentation. And I must say I'm having a little bit of a network issue here. I keep getting logged out and in. So I have some questions already on the chat, and I have addressed it to each of the presenters. So the next on the program is to go straight to the question and answer session, and Dr. Williams will be in charge of that session.
All right, let me. Okay,
Dr.
so
Williams?
Yes, can you hear me?
Yes.
Okay, so the first question is from Kabiru Amusa, and that question is for Matthew. Kabiru is wondering what led to the sudden division among traditional healers, in Ibadan, Ewa, Ijebu, and other places. What led to that division? And he also has a follow-up. The registration of native healers was a means to regulate the number of those who engage in such profession. If that is true, can we then say that their failure to achieve it was responsible for the 1916 Forest Ordinance that deprived majorly the locals from making use of the minor forest products? And I'll turn it over to Matthew.
Thank you very much for that. And thank you, Mr. Kabiru, Dr. Kabiru, for the questions. So first, talking about the division, we should know that the Edda, Ijebu, and these are like ethnic nationalities that actually, in terms of like the health procedures or the traditional healthcare procedures they have are actually quite different from each other. So what really like unify their interest is this formal identification and registration with in terms of forming an association to get recognized by the colonial government. So like what really led to their division at first is more or less like each ethnic traditional health practitioners at first, formed their own, units, Ibadan, Edba, and this thing, like because Ibadan healers method is different from Edba healers method. But then they came to form a unified, organizations in order to be generally recognized under the colonial government policy. I don't know if that answers that. And then talking about, the Forest Ordinance 1916 rather. First, I want to point out that the old formal registration of herbalist or Onishegun in southwestern Nigeria then, yes, was a form of limiting, how many people really participated in this, traditional medicine practices, and also it's also a form of capitalism and expropriation and exploitation, because as at this period, I will put it to you that, this, industrial baby milk, all these several, products were already flowing into Nigeria at this time. And now it's a thing of discouraging people from, consulting traditional healers and consuming Western medicine, and especially in the maternal area, buying all these things, right? Then in terms of the linkage to the 1916 Forest Reserve list, now most of these traditional healers definitely have to engage the, because they make use of herbal medicine, basically. Now, this might also be a means of discouragement or so from these traditional healers having access to the type of medicine that, that they really, practice with. Then the question would be, the forest ordinance, which are the forests targeted by this ordinance? Then when we ask this question of which are the forests that were actually probably restricted to the minor people or the local people, then we see are these forests, to some extent significant to some traditional healers in that particular area. So these are the questions we still have to explore. Thank you.
All right. Thank you for that. I'll follow up with that. There's another follow-up from Kabiru. I'll bring that up later. But this next question is also for you, Matthew. It's from Abimbola Adelakun. And she says, from your data, it seems to me that Onishegun and herbalists of the colonial era were not resistant to Western medicine or colonial government. Rather, they actively worked through its system of administration and even its media, for example, newspapers and magazines, to build their own spaces as healers. So if they could go through these modern processes to generate their own category, there is every possibility that they also appropriated methods from Western medicine as well. In that case, do these Onishegun/herbalists not qualify to be called modern as well?
Thank you very much for the question. First, I would say, to some extent, the reason why I refer to these as resistant is actually based on the data that came across at the archives, because they are personal stories of some herbalists or healers, although they did not even probably acquire this certification, they still practiced. And anytime the colonial officers or the colonial official actually coming to them, other herbalists rise, they actually support such herbalists that did not acquire the certification. So it's a means of yes, some people are actually acquire the certification, but others are actually against this acquiring of certification. So this manuscript or this research should be published soon, and there I made specific case studies. Then about referring to Onishegun as modern, I think then the question also is what exactly is modern, and then probably we have to unpack the concept of modern, or in this context, because to some extent the whole argument also is that yes, traditional health practices in traditional health practices magic, it comes with this for the colonialists, it comes with this notion of black magic, it comes with this notion of bad medicine, then it comes with this notion of it is not scientific, right? So that categorization of saying probably the colonial government will actually see this traditional health practitioners as modern, or we saying probably yes, we can call them modern, right? Because it's also a means of bringing one herbal medicine to the other and producing something more significant to cure certain illness or wellness or so. But then from the colonial government perspective, they don't see them as modern.
All right, thank you. And this next question is for Dr. Omobowale, and this is from Flourish. She says, the popular term, Olorunlo Owomo Were, forgive me if I butchered that, as you've used all through your presentation, what is its implication on child mortality? How has this affected modern healthcare provision for women and children in Nigeria?
Okay. Hello, can you hear me?
Yes.
Okay. Thank you. I think the statement is one of the palaces among the Yoruba, especially when you seems to have fail in court and you think you don't have control over circumstances. And when you make that statement, it means you are resigning to fatalism. That is one. And then the implication of these on child mortality for me is when mothers are encouraged to use such dismissive constructions, and these dismissive constructions among mothers of under 5 is not deconstructed, because if you look at it, a child is supposed to get a dose of for instance, BCG that prevents PT, to prevent diphtheria, pertussis, and tetanus. All these are diseases that are preventable, but can either lead to mortality or morbidity in children. And currently in Nigeria, the expanded immunization program provides this routine vaccines for children to prevent these preventable diseases. And the implication of not completing the dose of DPT now, and the child is not protected. It's like not taking the vaccine at all. And it means when the child is vulnerable to these diseases that could cause either mortality or morbidity. Then the implication for modern health provisioning and children is that it will encourage immunization of baby vaccine or modern healthcare usage hesitance and boycotts, if that's the way I see it. And the perspective I'm looking at this is that, of course, the statement has its own, usage among the Yoruba, but it has taken on a new dimension of construction and interpretation that has to do with health. And don't forget that health of a child is also equally important as health of the mother. And when a child is sick, the mother is equally sick. So what I'm saying that deconstructing this kind of new construction will help in we help the mother healthcare facility provisioning to thrive than it is thriving now. I don't know if I answer a question. Thank you.
Thank you. Thank you for that answer. The next question, that's for me, and that's from Abimbola Adelakun. She says, in the 90s, family planning messages were all the rage with television and radio campaigns. Do you have any information about that period? At that time, Nigeria was also under military rule, and IBB proclaimed the idea of 4 children per family. After a while, all these messages ceased. Can you speak specifically to this period? So for this particular study, I ended in the 1970s. So I end where IBB comes in and where some of the economic issues of the 80s come in as well. So I don't look at that period for this study, but I can speak a little bit for the period anyway. So the 80s, if we remember, Nigeria faced an economic downturn, and that began to change. In fact, that began to change the military government's rhetoric surrounding family planning and birth control, where the government had previously, like I said, remained detached from being actively involved or pushing specific policies. Now they began to advocate for some type of family planning, limiting the size of the family because there was an economic downturn. There was the structural adjustment program fiasco where the government, IBB government actually, where the government at the time would reject the structural adjustment program from the World Bank, but implement it anyway, implement the terms anyway, and the hardship that that caused. So that forced the government to begin to imagine 4 families, a 4-size family as a solution, family planning, limiting the number of families. So in order to minimize the economic pain in the families, but this became controversial. As you know, it didn't go too far, it didn't go anywhere really. It became controversial when I looked at Newswatch and some other magazines from this period for different projects. There was this whole argument about the North versus the South. The idea became, is this 4 children per wife? Or is this 4 children per household? And then, so in the case of the North, where many at the time married up to 4 wives, the Southerners argued, does this then mean that in the North, each wife would have 4 children? And then, so one household is entitled to 16 children, while in a Southern family, for those who were married to 1 wife, they had 4. So there was a whole lot of controversy around that period. But that was also, as you rightly pointed out, when a lot of family planning messages that was the aim thing at the time. And a lot were also targeted at men. My brother's children, I don't know if anybody knows or remembers that, but my brother's children became popular, this popular TV series, and this was all about family planning. And this was actually popular. Men watched it, women watched it. It's generated a conversation on birth control and on family planning. Now, what I'm not able to speak to, and maybe, hopefully I'll be able to speak to that with the new project that I'm embarking on, is what happened to those conversations. Because as you pointed out, it ceased. It just stopped happening. Enter the 21st century, and all of those conversations just slowly declined. So I'm wondering if anybody in the audience has ideas as to, I have ideas, but if anybody has ideas as to what happened with all those conversations, besides the unstable, inconsistent government that was plaguing this era, but also the inability of one government to the other to transition ideas across governments, across what do you call it? Yeah, across different leadership, political dispensations. I'd be interested to hear that. And then I think, oh, this question is for Matthew, and then I'll go to another question that's actually for me too. Matthew, this is from Flourish. She says, I understand that there were some colonial policies made to restrict drastically the activities of traditional healers and medicine men. How were they able to maneuver these policies, and what was its implication on health and healing practices in colonial Ibadan in particular?
Thank you very much for the question, Dr. Flourish. Yeah, so these policies actually like the ordinances on yeah, the certification thing, and then the ordinances on not worshiping Shokmono, not engaging in Okebado festival things. I mean, these were like targeted at the practices of this tradition, and then how they were able to maneuver it is just talking about the advocacy tools they used in terms of like maneuvering it, in terms of like having this, formal identity of organizations, formal organizations. However, by the side, these, traditional healers still engage in all these, practices that the colonial government had actually, listed as, like the colonial government had actually blacklisted. That's why, this document, you see that some traditional, healers were arrested, even though they had this certification, even though they joined these organizations, they still practice, all this blacklisted medicine. And the whole argument is also that this medicine that we practice is not Black medicine. This is just us continuing what we've already been doing. Then the question of, so what were like the indigenous people's reaction to all these, controversies or contestations, right? And this is a particular area which I will extend my further research to. And I'm talking about the implication on health and healing. To some extent, the voices of like the traditional health practitioners actually kept on like going down, right? And that's why like in the post-colonial period, you see in newspapers, which recently at the National Archives of Ibadan, I think last week, I came across, a comment that, yes, by traditional herbalists, in the Daily Times, there's like this tag, like they blacklisted us as juju practitioners. They don't even include us in colonial development plans. So like these are the implications and then the interplay. Because like you see that over time, these people just, kept on being downplayed and relegated. Although the United Nations in the 1950s, 60s came up with policies about, oh yes, we should recognize traditional healthcare. We should include traditional healthcare practitioners in our agenda. But then for Nigeria, like it wasn't like really implemented. I don't know if Tarian says. Thank you.
All right. This is Matthew. This is kind of related to the question that you just answered too, and it's from Kabiru Amusa. So Kabiru says, to what extent can we argue that the traditional medicine superseded Western practices in the colonial era, given the 1926 business ordinance under which the traditional medicine was categorized?
To make such arguments that if traditional medicine actually superseded colonial medicine, I would not like to engage in making such an argument, because like it's obvious from all indications, from the development plans, from the programs and policies, from the way traditional healers struggles to form associations, from the way they still like try to keep themselves in the system, we can see that this is more or less like it was a difficult situation, fighting for recognition and identification in a system that's actually as an alternative medical care for the people. So it was very pluralistic, that it's not even a matter of, oh yeah, traditional medicine superseded colonial medicine. No, it's not really about that argument. It's about the argument of preservation, which thank you.
All right, so this other question, this is for me from Matthew. It says, what was the question of reproductive health rights during the population control period? So when you say population control period, I would imagine you're talking about the period before the 1960s, when the rhetoric was about population control and sometimes was even cast in racial terms. For Nigeria in particular, that was not really a conversation that was being had. It was being had elsewhere, especially in the West, in the Caribbean, but that conversation was not happening per se at any large scale in the Nigerian setting in the 40s or even 50s, because of where the colony was at the time. I mean, maternal health care had only become this major thing that the colonial government itself, apart from missionaries, that the colonial government itself began to take seriously only in the late 30s and increasingly so in the late 40s. So the conversation about reproductive rights, health rights in the colony of Nigeria was still quite premature. Now, for the post-colonial period, when the rhetoric became family planning, birth control, and then family planning, this is part of the threads that I'm trying to piece together in the research. This is an element of the research that I haven't looked into a lot, something that I'm hoping to explore, because at this time there's the women's rights movement globally, and Nigeria was a part of that conversation beginning in the late 1960s and then in the 1970s. So part of what I'm going to look at, or part of what I'm trying to look at, is to see how that factors into all of this conversation about birth control and about a woman's right to actually have contraceptives or not, and a woman's the ability of the husband to censor the woman by granting his signature. So this is something that I'll look at for the post-colonial, the period when the rhetoric was family planning, but for population control period, that was something, that was not a conversation that we could have and we were having in the colony of Nigeria. I hope that answers your question. I believe there's another question in here from Flourish. So Flourish says, religion and ethnicity, as you have rightly mentioned, are major factors that affected the introduction of birth control in Nigeria. What are the linkages between ethnicity and religion in the traditional settings of Nigeria? So I'm trying to determine if by traditional setting, you're talking about traditional birth control methods, or if you're just talking about in the local setting, how did people view birth control in the lens of ethnicity and religion? And these two themes played out, especially religion, more religion than ethnicity. That kind of colored a lot of things. It wasn't just traditional religion versus other religion. It was also like different sects. For instance, the Catholic Church, the Pope issued a statement, I believe it was sometime in the 60s, and specifically said that birth control was bad, that when Pope John Paul visited Nigeria II, he specifically had a campaign around birth control, and he condemned it, and he said that true Catholics should not practice it. It was an attack against the family. And then when it comes to Islam,
Dr. Ogeshi, I would want to cut short. We're already getting a notification from the technical team that we will stop in 1 minute exactly. So I guess we'll have to take up this discussion further outside this platform.
Yep.
I think you should give us the closing remark and we can end the session.
All right. Well, thank you everyone for coming. This was wonderful, and hopefully we can stay in touch and we can continue this conversation, considering that we're doing similar work, and hopefully we get a chance to actually get together in person and discuss a lot of the interesting things that we're doing. So thank you so much for taking the time to join us today, and I look forward to catching up with you at some point in life.
Thank you.
Real life.
Thank you.
All right, bye.